now Simon Morley is one of our radiologists who is probably the best ultrasound operative I've ever seen. If ever I needed somebody to stick a needle in my neck, I'd run for the... No, I'm sorry.
So thank you very much for asking me to speak today. So I'm Simon Morley and I'm a head and neck radiologist at University College Hospital. So what I'm going to do today is just speak to you about using ultrasound as an imaging modality for guiding photodynamic therapy, interstitial photodynamic therapy. And really the main area that I'm going to talk to you about is treatment of tongue-based tumours. You may say, well, I pick tongue-based tumours. These are very difficult to treat because it's an awkward area for the clinicians to get to. So if you look in someone's mouth, trying to look sort of backwards round at the tongue base can be hard. So it's quite difficult to do direct visualization of this area just looking through the patient's mouth. And if the patients have tumours which recur following conventional treatment, they can be very symptomatic for the patients, both in terms of swallowing and breathing and so on. So the images here demonstrate a patient who's got a very large tumour which has arisen from the tongue base. And you can see all of this grey tissue here is all the tumour in the tongue and underneath the tongue. And you can see that here on the coronal image. Now this patient has had treatment with conventional chemoradiotherapy and the tumour has recurred. And so we're really moving into a setting where you're either looking at treatment with experimental drugs, chemotherapies, or looking at alternative options, really in a palliative setting to try and make this patient more comfortable and until the tumour ultimately catches up with them. So once you've exhausted your standard treatment options, what are we into? Well, we're into palliation in terms of symptom control. Can you reduce the bulk of the tumour there? Help with breathing, speaking, swallowing. Some of these patients have a pretty unpleasant smell from their mouth and the discharge. And also reducing pain. So this is where I came in working with Colin at UCLH. Some pretty unfortunate patients who've reached the end of the road with conventional treatment who are trying to really help with palliation. And interstitial photodynamic therapy offers a possibility to help these patients. Now, as Colin said, my background really is I'm a head and neck radiologist and I particularly specialise in ultrasound. And I don't know why, but over the years I've just got really keen on doing ultrasound guided biopsies and biopsy related procedures. I would say to my wife, I'm at my most relaxed when I've got a needle in somebody's neck. Ideally, if you were trying to sort of put needles such that you covered the whole of the volume of a tumour, so you've got the needles equally spaced out, you would use something a bit like this, you know, something to hold the needles and place them. And this all looks good, but in reality the tumours are three-dimensional, the skin surface is all a bit wonky, and you line it up and you put them in and it's not quite in the right place, and it sort of just doesn't really work. So what we find is that you can see on ultrasound these tumours and you can kind of see their three-dimensional shape as you scan through. This is not a patient who we treated with PDT, but it's just to show you the example. I'll just show you the anatomy. This is the left side of the neck, that's the submandibular salivary gland. And then this is the back of the tongue, and it sort of curls around onto the tonsil here, and that's normal sort of lingual tonsillar tissue. And what you can see on this side is that there's this much thicker, darker area curling around the corner, involving the back of the tongue here, and then curling around the glossotonsillar sulcus. So you can see these tumours relatively well on ultrasound by just putting the probe here. It's not that far in under the skin to get to that area. And of course, with a bit of practice, and that's why I've got one up on you guys, you can put a needle in anything on ultrasound so long as you can see it on ultrasound. So you need a kind of direct line of sight for your ultrasound beam. If you've got tissue all the way to the tumour, you can see it, but if you've then got air and then your tumour, so it's on the back wall, then you wouldn't be able to visualise it. And for those of you interested in giving this a go, it's actually not very difficult, the concept. Essentially what you do is you line up the ultrasound probe and you get the thing that you want to stick a needle in on the screen. And then all you have to do is concentrate on getting the needle absolutely in line with the ultrasound probe, and that's the trick. As soon as you start deviating off slightly to one side, you'll miss it. So you've got to just be absolutely straight down the barrel of the gun, making sure that the ultrasound probe is looking at what you're looking at, and lots of practice. I worked out I've now done about 35,000 neck ultrasounds, and I've probably done about 4,500, 5,000 biopsies. So I've had lots of practice, and this is what happens. So when you look at a patient with ultrasound, this is what the needle looks like. It reflects the ultrasound beam, and that's quite a nice picture, isn't it? You can see it very well. Of course, the more horizontal your needle is, the easier it is to see. The more steep and vertical, the less reflection there is back off your needle, so it's more of a struggle. And you can clearly see the needle tip there. So what this allows you is a real-time ability to place needles in a three-dimensional complex volume. Now, there's a lot of trust here. Colin has to trust that I'm sort of placing them in the right way. But you can scan through, as you scan through the volume, and you can go, okay, we've got a needle there, we've got a needle there, we've got a needle there. And you can scan it, of course, in different planes and make sure that they're fairly well spaced out to do the treatment. So really the main skill here is one of ultrasound and needles. You've got to be able to place a needle where you want to. Now what I'm going to show you now is a picture. I'll just scroll through it. It's a kind of movie loop, and we'll go backwards and forwards through it a few times. Okay, so this is a patient who is scanning their back, the right posterior tongue base, and this poor chap's had all his conventional treatment, which has failed, and he's got this residual tumour here. So you can define the outline of the tumour with this hypoechoic tissue, and this is a tumour ulcer around the base of it. And you can see as you scan through it that this is where the tumour ends. This is inflammatory tissue and normal tongue tissue. So the tumour's got these little blobby bits coming off the side of it like this. So what we have to do is to go through that volume of tumour in that tongue base very carefully. And what we've done here is just taken a picture. I've sort of outlined where the tumour is sitting. And then what you can see here is my needle come in, and there's my needle tip. Now I don't want to breach the mucosal surface here, otherwise the light is going to start shining into his pharynx. What I want to do is get the needle so it's within the volume of tissue. So that's where I'm going to position it, just away from the mucosal surface. And you can see this is a centimetre. So we're going to treat this volume around here. So that's the first treatment we would do with that particular needle. And then in order to treat the tissue here, we would then pull the needle back and do a separate treatment. So you have to do, first of all, put all your needles in place so that they're spaced through the volume, so you're treating the whole volume. And then secondly, you've got to pull back the needle so that the whole volume is covered. And this is basically what we end up with, and this is one of the patients who's got a much larger tumour that we're treating. You can also treat lymph nodes. These are some nodes in the neck. So what are the advantages? It's quick compared to other techniques like MRI, which is a real faff. The equipment is cheap. I may not be cheap, but the ultrasound machine is cheap, the needles are cheap. And what are the issues? It's not really a curative option, it's a palliative option, and it is dependent on who's putting the needles in. And probably the main issue for me is that as I put the needles in and you do the treatment, you see no real-time change in the tissues. If you actually saw a change in the tissue, you could go, oh, I've treated that bit, or I've missed that bit, and so on, and that makes it more difficult. What are the results on this? Well, we treated 33 palliative patients with stage 4 tumour. Other treatments have been exhausted, and in them, 14 of them had breathing problems before the treatment, and 11 of those, they said that their breathing had improved. 28 had 33 had swallowing problems at the time of the treatment, and 28 said that their swallowing had improved. And also speaking, we had 15 out of 18 improved on that. So, you know, it's just showing you that it's feasible and it may improve these patients' quality of life. Okay, I think I'll draw it to a close there because we're at risk of overrunning.
Thank you very much.